Thank you for the opportunity to present our study titled Predicting Survival After Radical Prostatectomy, Variation of Machine Learning Performance by Race. Prostate cancer is the most common cancer diagnosed in U.S. males. The majority of patients that receive treatment undergo surgery known as radical prostatectomy. Race is an important factor in prostate cancer biology. Compared to whites, blacks have higher incidence, worse stage of diagnosis, and higher mortality rates. As this audience knows well, machine learning models are increasingly being used to develop predictive models in healthcare and may eventually be used to develop a model predicting survival after radical prostatectomy. However, these models learn from the data that they are trained on and are therefore prone to bias. This is particularly concerning in prostate cancer, given the influence of race on prostate cancer biology, and that large prostate cancer databases consist predominantly of white patients. Therefore, the objectives of this study were to evaluate whether the performance of a machine learning classifier predicting survival after radical prostatectomy would vary by race, and to evaluate whether the performance would vary based on the racial composition of the training set. For this study, we used the National Cancer Database, which is a hospital-based cancer registry and captures over 70% of newly diagnosed cancers. The database is considered representative of care across the United States and is comprised predominantly of white patients, considering the source population. We included patients undergoing radical prostatectomy for localized prostate cancer, and we categorized patients based on the race variable into white, black, and non-white, non-black subgroups. The features in the model were demographic, clinical, and provider characteristics. The label was survival at 5 years. And we trained the classifier in 5 different settings: 1 in the naturally race-imbalanced sample, 3 in race-specific samples, and finally 1 in a synthetically race-balanced sample. We used the XGBoost model and evaluated SHAP values for feature importance. The primary outcome was the F1 score, considering the clinical priority of predicting those with death. The cohort consisted of approximately 70,000 patients, 84% of whom were white, 12% were black, and 4% were non-white, non-black. The F1 scores were highest in the black test sets and lowest in the non-white, non-black test sets. The poor F1 scores in the non-white, non-black test sets cannot be solely attributed to their relative minor proportion of the training sample, as the highest F1 scores were observed in the black test set, despite them representing only 12% of the original sample. Furthermore, we found that the classifier's performance was relatively invariant to the race composition of the training sample. When looking at SHAP values, the race imbalance model was similar to the black and white models, but the non-white, non-black model demonstrated weaker SHAP values. These results suggest that the features included in the model were more predictive in black and white patients compared to non-white, non-black patients. Overall, our results emphasize the importance of evaluating model performance in patient subgroups prior to clinical deployment. Furthermore, the non-white, non-black subgroup constitutes a heterogeneous group, and developing robust algorithms within this subgroup may be challenging. This brings forward the ethical dilemma of being able to develop predictive algorithms for some patient subgroups and not others. Thank you.